manifestation of a systemic disease on the skin. And there are very many other diseases that have skin manifestation. So sometimes the thing that you see on the skin may be just a manifestation of a systemic disease. And then, of course, we have disorders that are primarily skin. That is talking about the dermis and epidermis. And these are very common. Yeah. And most of the vast majority of them are inflammatory or neoplastic. When you talk about inflammatory, so you're talking about dermatitis, different types of dermatitis. You talk about inflammation, which could be chronic or acute. But when you talk about neoplastic, it means it's either tumors, which could be benign, or malignant. So most of the primary skin conditions, that is basically the condition that affect primarily the skin, will be majority of them will be inflammatory or neoplastic. That is has to do with tumors, either benign or malignant. But of course, there are other conditions that will still affect the skin, but the vast majority will be uh, related to inflammation or neoplasm. And then there are some terminologies which will be important, of course, for all of us to keep going back. I know there are some hard sounding terminologies, but I think it's good to familiarize yourself with them, because when you look, even as you move on in future, when you go to the clinical area, you start seeing diseases and so on. These are some of the terminologies that they will use. But most of these that we are talking about responses to or of the skin to injury. So injury to skin could be scratching, mostly. These are some of the changes that occur. For example, you talk about orthokeratosis. You're talking about thickened layer of normal keratin. So the keratin is there. That is the conified layer, but it is thickened. So it is thicker than normal. But the keratin itself is normal. That means those cells are normal, but they are thickened. Yeah, so you can call it also hyperkeratosis. Non-nuclear fragments. So you don't see any cell that have a nuclear in them. So this orthokeratosis is usually associated with prominence of granular layer. Remember the granular layer. So that is why it was important for us to be able to go through all those layers. So you can always go back and look at the layer, the granular layer. So there is prominence of that layer. We call it hypergranulosis, that granular layer, just before you come to the keratin. So this orthokeratosis is commonly seen in skin which has been chronically traumatized by scratching. So a skin that has been traumatized chronically by chronic scratching and so on. And usually this one leads to thickening of epidermis, which we call that acanthosis. So thickening of the epidermis, another name is acanthosis. So it's good to remember those terminology and always go back and look at those layers of the epidermis to be able to really be able to understand. Then there is what we call parakeratosis, which is an abnormal surface keratin with residual flecks of nuclear material. So in this case, the surface keratin is abnormal with flecks of nuclear material. So you can see some nucleus and remnants of cells with some nuclear in them. Remember, as cells rise, they tend to lose the nucleus. So there's a bit of nuclear material in this case. Of course, all this is looking under the microscope. This is a tissue, a skin tissue that has to be prepared, has to be done also sectioning and maybe staining, and then looking under the microscope. Then this is what you would see. So this is often this parakeratosis is often associated with loss or diminution of granular layer. So think of that granular layer. So that granular layer tend to be lost, or it becomes very small. It becomes diminutive. That is, it reduces in size. Yeah, that is if you compare with the normal size of that granular layer. So it occurs in a range of conditions, but may be associated with dysplasia affecting underlying epidermis. So remember, it's good also in this case to remember, go back and remember what was dysplasia. So go back and read again what was dysplasia. We defined this in pathology 1. Yeah, that is in last year, pleasure. So it sometimes is, and dysplasia, sometimes if you don't control it, may go on to become, for example, malignant. Then there is acanthosis, which is thickening of the epidermis, usually associated with increased depth of rete-pegs. So it's good to go back and look in those diagrams that we talked about where the rete-pegs are. So their depth increase. That means they tend to become longer. Their depth tend to increase of rete pegs. This is usually due to an increase in the depth of stratum spinosum prickle cell layer. So stratum spinosum can also be called prickle cell layer. So go back again and look at that diagram, those diagrams that I've given you, and see where the stratum spinosum. Stratum basically means strata. You remember strata is something that has layers. That is why we talk of stratified. Yeah, so you look at that spinosum, that stratum spinosum. So in this case, usually tend to increase in depth. It's a common feature of many skin conditions, particularly chronic inflammatory conditions. So chronic inflammatory condition, this you are likely to find acanthosis in such conditions, and most of the conditions of the skin would be inflammatory. And there would be associated thickening of granular layer. So there is also hypergranulosis overlying orthokeratotic hyperkeratosis. So of course you need to remember what was orthokeratosis, what is hyperkeratosis. So combining the two, so they are both orthokeratosis and hyperkeratosis. Then there is spongiosis. Yeah. So these are intraepidermal edema. So we talked about edema. I think that was in pathology 1 also. So when you talk of something intraepidermal, that means it's inside the epidermis. So remember the epidermis with all those layers, either 5 layers or 4 layers. So this edema is inside the epidermis. That is intra. So when you talk of intra, it's inside the epidermis. So it's intraepidermal edema due to acute inflammation. And of course, inflammation we talked about also, so we know what acute inflammation is. There'll be, of course, cells like neutrophils and so on. And this one results in gaps between keratinocytes. So those cells, so there'll be gaps between the cells because the fluid is what will fill those gaps and will create a gap and highlighting intercellular junction. So in this case, when the cells are separated, gaps are there where the fluid will be accumulating. Then the intercellular, that means junction between cells will become highlighted. That means they'll become more prominent. And of course, this one, you remember, is microscopic anatomy. This one you can't see with a naked eye. You have to look under the microscope. It's microanatomy. And remember, this fluid, this edema fluid may coalesce to form intraepidermal vesicles. So vesicles are basically fluid-filled lesions. Yeah. So remember, this fluid may coalesce. Coalesce is to join one another to form a bigger intraepidermal vesicles. Now remember, initially it was just the edema fluid, but now when they coalesce, you form a vesicle. Spongiosis with vesicle formation is a feature of acute dermatitis. So when we talk about acute dermatitis, remember when you talk about dermatitis, you talk of inflammation. So spongiosis, so you think also about a sponge. It appears like a sponge when it, so to speak. So it's a common feature of acute dermatitis, spongiosis. And then just a bit of also definitions of this. We're talking of vesicles, which we've already mentioned, small accumulation of edema fluid within epidermis due to acute inflammation. So that one you'll call a vesicle. Then you'll hear of a bulla, which is a large collection of fluid within or beneath the epidermis. So in this case, basically it's a bigger vesicle. So a larger vesicle becomes a bulla. Then a pustule, as even the name would suggest, there is pus, probably pus, so inflammation. So a collection of neutrophil polymorphs and some fluid within. So it could be within or beneath the epidermis. So it could be inside the epidermis or beneath, just below the epidermis. Yeah. Maybe subcorneal. Yeah, so it may be just below the conified layer. That is below the keratinized layer. Or it can be inside the epidermis, or it can be some epidermal just below the epidermis. That is between the epidermis and the dermis. And then, of course, another thing that is very common is burns. And I'm sure for those of us who've rotated in surgical ward, especially ward 2, where children are usually found, there are a lot of burns. And our ward, you will never miss burns. Even right now, there are 1 or 2 children who are presented to the hospital with burns, and we are managing for burns. So there will always be burns. And burns, of course, as we had talked, I'm sure we mentioned probably in pathology 1 or in anatomy, there are different, you can talk of degrees of burns. So you can talk of superficial burns, you can talk of second degree superficial burns, second degree deep burns, you know, and so on to that degree. And maybe by the time you're talking of fourth degree, possibly it has gone all the way to involve the bone, for example. So, and burns, of course, so it involves destruction. Mostly superficial one will just affect maybe the epidermis. So the deeper one will go all the way to the dermis. So burns, of course, is a common condition that all of us will manage. I don't think if you ever work in a hospital, you'll never fail to see a patient with burns that you'll have to manage. Of course, as you move on and advance on, you should now be able to be taught how to manage burns, the treatment for burns, how to manage them, and so on.